So hopefully you can see my slides. So yeah, I'm talking about the importance of research in specialist palliative care. And this is my declaration, my conflict of interest. So I'm paid by the universities to undertake research. So I'm obviously going to be very pro-research. But as Noreen mentioned, although I'm currently a full-time academic with clinical sessions at Our Lady's Hospice and St James's Hospital, throughout my sort of consultant career, I've been mainly a clinician. And I've always been struck by how much of our practice in palliative care is not evidence-based, and how some of it seems counterintuitive. And I'm going to pick up that point as we go along. And one thing that I'm going to come back to later on in the talk is why we need to think about research now. And the title of this conference is Wither or Evolve. These are some of the headlines from the Daily Mail around the Liverpool care pathway. And I'm sure you're all very familiar with the Liverpool care pathway, but in around 2014, the scandal, if you like, reared its ugly head again. And as a result of a review, the Neuberger review, the Liverpool care pathway was abandoned in the United Kingdom. So as I was saying, was talking about the Liverpool care pathway and the problems that occurred when actually not only the problems about the review and the feedback from patients, well, from carers predominantly, but the impact it had on the ongoing care of patients. Because when the Liverpool care pathway was abandoned in the UK, there was a vacuum of care, and particularly non-specialists are very concerned about how patients are managed, and particularly about the use of potentially sedating drugs. So end-of-life care for a period of maybe 1 to 2 years in the UK suffered significantly. And one of the reasons why the Liverpool care pathway failed is because it was implemented without appropriate research. And I'll come back to that a little bit later in the talk. And this is something that we frequently come across in palliative care, or at least I frequently come across in palliative care, is when you ask people why are they doing a certain thing, the answer is because that's the way we've always done it. And when you ask them, but how did you decide this was the way to do it in the first place? Most people don't know. It's just what they were taught when they first started at the institution. Nobody's ever questioned it. It's what everybody has continued to do for 10, 20, 30, 40, 50 years. And everybody seems to be happy to continue to do the same thing. And I always question, how is it that every other branch of medicine is completely different to how it was 5, 10 years ago? And yet most of palliative care is exactly the same. And indeed, if you just look at every aspect of life in general, there have been huge changes even in the last 5 to 10 years, with the development of, for instance, technology. So how is it that what we were doing when St Christopher's Hospice opened in the late 1960s, how is it that can still be relevant? And I think the other thing that strikes me as well is that, we all have to do on a yearly basis by training and other mandatory training. But for many of our colleagues, there's no incentive to continue with their learning in terms of palliative care. And I just mentioned St Christopher's because I think a lot of practice has sort of a lot of our current practice is related to work that was done initially at St Christopher's and the original sort of textbooks that we use were written by people who, if not working at St Christopher's, certainly trained at St Christopher's. But I think we forget that when Cecily Saunders set up St Christopher's, one of the things she was very keen about doing was actually researching undertaking research so she could improve the care of the patients. And this is a quote from the St. Christopher's website as part of the sort of celebration of their 50 years since St. Christopher's was opened. And indeed, St. Christopher's had, in the basement, had a post-mortem room where they used to do post-mortems to try and get a better understanding of the underlying pathophysiology of the problem so that they could develop therapeutic interventions. So the birth of modern palliative care was very much, research was very much embedded into St. Christopher's and similar services. But over time, we seem to have lost the emphasis on the importance of research in terms of care. And I think this is the philosophy that Cecily Saunders had, and certainly I have, is that clinical practice should be driven by the research. And more importantly, the education that we give, particularly to non-specialists, should be driven by evidence-based clinical practice. So what we teach undergraduate medical students, and undergraduate nurses and AHPs, we shouldn't teach them a simplified, sanitized version of palliative care. We should teach them actually what is going on in the real world. And I'm sure that most of us believe that we are giving the best care possible. And I'm not suggesting that any of us aren't providing very good care. But how can you give the patient the best care if nobody knows what best care is? Or even more importantly, if you and your colleagues don't know. So if your colleagues are not keeping up to date, are still just using the same things that they have 5, 10, 20 years, then probably you're not giving the best care. You might be giving very good care, but not the best care. And I think that's the thing that I would like people to think about at the end of this talk. It may be that you don't agree with much of what I'm about to say, but what I'd like is people will go back and look at what they do and look at why they do it and whether there are alternatives. And the other thing I want to highlight is this issue about individualized management, individualized care. We're very protocol driven in palliative care, as in many areas of medicine, but it's very clear that sort of cookbook palliative medicine, for example, things like using the WHO 3-step ladder to manage cancer pain is outdated. And so we need to look at providing personalized care, individualized care. And in fact, if you look back at lots of the early publications from St. Christopher's Hospice, that was actually what they did. They had a pharmacopoeia, had a list of drugs, but they didn't have protocols of such how to manage pain or other symptoms. So just a few brief slides about evidence-based medicine, evidence-based practice. I'm sure most of you know about this. So this is a very famous quote from David Sackett. And it's about applying the evidence as much as knowing what the evidence is, and particularly in terms of individualized care. And the other thing is it's about applying all the evidence, not just about applying the evidence that fits with your clinical practice, with your views of the world. And that can be difficult, particularly if you've done something the same way for a very long period of time. So this is the evidence-based medicine pyramid. So in an ideal world, we'd like meta-analyses based on multiple randomized controlled trials to guide our practice. But in the real world, there are very few things that we actually use on a day-to-day basis where there's that level of evidence. And in fact, I think a lot of our practice is actually driven by experience, which in turn is driven by expert opinion. That's fine if there isn't any alternative sources of evidence, but we need to understand that's why we're doing things. And I would say we need to then go and do the research to confirm actually that what we're doing is, the right thing for the patient. And I'll come on to talk about some things that have changed over time as a result of doing research. Okay, so I wanted to just start this section by looking at this parabola. So this was a very short article in a Christmas BMJ from many years ago, and it was written by a consultant gynecologist, and it was to highlight the fact that surgical practice was not evidence-based, and how new techniques, new equipment would often come into practice with very little evidence. And often that led to problems and the intervention falling out of favor. And a good recent example of that would be the use of mesh to treat various problems, when we're seeing patients who've had mesh inserted into them for different reasons, having chronic problems, chronic health problems as a result of the mesh, and even removing the mesh does not necessarily improve those symptoms. And when I first came into palliative care, one of the big favorites in terms of managing breathlessness was the use of nebulized opioids. So this is Scott's parabola in a sort of more formal version. And this really explains, I think, how certain techniques, interventions become standard practice. And in terms of things that have fallen by the wayside, what happens, what is their natural history? And to sort of support this, I'll use the example of nebulized opioids. So there was a single case report in palliative medicine, followed up by a series of patients who had mixed etiology breathlessness, who'd been given nebulized morphine and who improved. And as a result of, very limited data, a handful of patients, experts in the field promoted this as the #1 treatment for breathlessness of any underlying cause, assuming that you've managed the primary cause. And indeed, the Oxford textbook of palliative medicine, in their section about management of breathlessness in the sort of mid-90s, the largest section of the chapter on the management of breathlessness was around the use of nebulized opioids. And then Carol Davies, who's a consultant in palliative medicine from Southampton, she actually did a randomized controlled trial and showed that it didn't work, that it was no better. Nebulized morphine was no better than nebulized saline. Subsequently, other people did some studies, and Louise Jennings did a systematic review in the late 1990s that confirmed the fact that there was no difference between nebulized opioids and nebulized saline. So something that was standard of practice, was recommended in the Oxford textbook, was based on some case series involving a handful of patients. I remember in our home care team at the time, we had tens and tens of nebulizers bought, and everybody who was breathless was given this treatment. A huge amount of resources put into this treatment on the basis of nothing. And what's very interesting is that you will still see anecdotal reports in the literature of people using nebulized opioids to treat breathlessness, using different drugs, using different nebulizers, producing different size droplets, etc., etc. So I think this is probably true of lots of our interventions, that if we actually did the research, we would actually stop using them, because we'd find out the interventions weren't very effective. And just looking at some things related to opioids. So again, The Brompton cocktail was very popular until particularly Robert Twycross did some research looking at different elements within the Brompton cocktail and removed things such as the alcohol, removed the cocaine, and then found it was the opioid that was actually the most. The double dose of morphine at bedtime, for those of you who have got grey hair, this was a standard practice. You gave a double dose just for bedtime of the 4-hourly dose of morphine, so that the patient allegedly wouldn't need to be woken in the middle of the night, would sleep through. That was complete nonsense, and it was nonsense from a pharmacological point of view. And when the research was done, they showed that patients who were woken up in the middle of the night had better sleep than the patients who had a double dose at bedtime. And more recently, the WHO three-step ladder has finally lost its endorsement from the WHO because of the fact that the research doesn't support it in any way, shape, or form. So I think a lot of our practice is built on shaky ground, and I think we need to acknowledge that. Now, it may be many of the things that we do when we do the research, it will confirm that actually they are very effective interventions and maybe the most effective interventions. But there is still this drive to instead of using things that are well researched, well validated, to come up with alternative treatments. And this is my current favorite. These are Vaseline balls coated in sugar to treat constipation. This was a paper that was published in the US, in the American Journal of Hospice and Palliative Care. It was a survey of palliative care teams and hospice teams in the US. And this is a common treatment for constipation in the US. I have to say that until I'd read this paper, I'd never heard of it. But it is widely being used despite the fact that there is no research. So I think there are lots of things, or there may be a number of things that we are using in everyday practice that actually aren't very effective. There certainly are many useful things that have been proven by research to be effective and to be well tolerated that are not used in everyday practice. There are some interventions that we use inappropriately, either ones that we shouldn't be using or ones that we should be using. And again, that's because, you know, we're using it in a way that, for instance, doesn't match its pharmacology, but because a key opinion leader, an expert, has suggested a specific dose or method of using it. And I'll give you some examples. So, as you may know, one of my big interests is in oral care. So these are things that are recommended in publications such as the BNF, in NICE guidance for management of, for instance, dry mouth and dirty mouth. These are all just completely illogical treatments. And our dental and oral medicine colleagues laugh at us when they read about the things that we recommend to manage our patients. Ice chips are just cold water, okay? There's no benefit to freezing the water. You put them in the mouth, they melt. They're no more effective than water. We shouldn't be using artificial salivas that are acidic. Clandestine, which seems to be on most lockers in the patient's IC, is contraindicated because it's acidic. A patient with a dry mouth already have an acidic mouth. Same goes for the pineapple chunks and the vitamin C tablets and sweets. So things that we regularly give and are recommended in our guidelines are not evidence-based and are actually contraindicated for the indications that we use them for. Interventions that are not used in everyday practice. So again, one of my interests is in opioid-induced constipation. So there are 3 interventions that are proven to work in opioid-induced constipation, backed up by randomized controlled trials, and in the case of Pomora's multiple systematic reviews. but they're very rarely used in practice. And I just wanted to just highlight one of the Pamoras available in Ireland. So this is the NICE technology appraisal guidance. So NICE are recommending the use of this for opioid-induced constipation. This is one of only 2 drugs, 2 interventions that are routinely used within palliative care that has a NICE approval. And NICE have approved it on the basis of efficacy and tolerability and, importantly, health economic data, and says that, you know, if a patient has opioid-induced constipation and has been on conventional laxatives for less than 2 weeks, in fact, only 4 days up to 2 weeks, and is still symptomatic, then they should be switched to Naloxegol. But in practice, this does not happen. This doesn't happen in the UK, it doesn't happen in the rest of Europe, and doesn't happen in Ireland. So treatments that are well researched, that are recommended, are not finding their way into clinical practice. And I don't understand that, particularly when you see other drugs like, for instance, pregabalin, gabapentin, which are, you know, given to lots of patients, despite the fact that the evidence for them it is non-existent, particularly in a cancer population. Interventions being used inappropriately. My pet hate is the use of benzodiazepines, particularly for delirium. They don't work unless the delirium is related to alcohol withdrawal or benzodiazepine withdrawal, but it's still used a lot. And then another thing is around hyacinth butyl bromide. So for whatever reason hyacinth butyl bromide is being used, the doses that are being used are inappropriate. If you look at the pharmacokinetic data, giving somebody 20 milligrams in a syringe drive over 24 hours, or even giving them 60, 80 milligrams, that is a suboptimal dose. Now, for whatever you're treating, whether that be abdominal colic, trying to reduce GI secretions with management of death rattle. Now that is too low a dose to have an anticholinergic effect. But again, we're not basing our clinical practice on the data, we're basing it on recommendations from key opinion leaders. And it's not just individual interventions like drugs. If you look at something like home care, so we all work in units with home care. Home care is an essential part of palliative care throughout most of Europe, although interestingly in Germany, community palliative care is not well established at all. But if you look at the evidence, so this is Cochrane review, it's slightly old now, but I don't think there's been much good randomized control data since then. Community palliative care, home care teams have been shown to increase the proportion of patients who die at home and appear to have appear to improve symptoms, but not interestingly pain, and have no obvious positive benefit on physical functioning, patient quality of life, attendances to hospital, so attendances to A&E and admissions to hospital, have no apparent influence on carer burden and carer grief. So you could argue that this relates to a dearth of evidence or the wrong type of trials, but we don't have the evidence to support our current practice. And maybe, and we're doing this within our department, we're looking at new models of community care to try and address some of these apparent deficiencies. I've got 5 minutes left. I'm going to quickly talk a bit about the Liverpool care pathway, because I think this is a warning to us in palliative care. So the Liverpool care pathway, as I'm sure you're all aware, was developed to try and replicate what happens in a hospice in a hospital. This is version 12, which was published around the time where the Neuberger review happened, so around 2013, 2014. what was very interesting was that the Liverpool care pathway was not standard in all institutions. So you could tweak it according to how you wanted the Liverpool care pathway to be administered in your institution. I'm just going to highlight a bit about clinically assisted hydration. So the implication from the document was that you really shouldn't be giving clinically assisted hydration to people who are at the end of life. And there is this statement about the fact that, symptoms of thirst do not indicate dehydration. That is not true. Okay, dry mouth does not necessarily indicate dehydration, but thirst is a sign of dehydration. So there was this implication that fluids are bad and you shouldn't give it at the end of life. You should just administer oral care. So when there was a big furore driven by the Daily Telegraph and the Daily Mail to look into this, the Neuberger review took evidence from many bereaved carers, and alongside there was a rapid review of the evidence. And I just want to stick to the fluid aspect of the Neuberger review. It goes on to talk about lots of different things, but essentially the problem was that the Liverpool care pathway was never researched. So the Neuberger review stated that we should be supporting patients with fluids more often. And actually that if you don't support patients, there is a significant risk that they will die from dehydration before they die from whatever the underlying cause is. But they did acknowledge that there wasn't any evidence. And this is the evidence of the time. So despite the fact that this is a fundamental aspect of our care, in terms of the number of patients ever being put into clinical trials, it's just over 200. And if you look at the trials, and I haven't got time to explain them all, these trials are flawed. They're not looking at patients who stop drinking and remain hydrated. These are studies that included people who were dehydrated, and they didn't rehydrate the patients. They gave them suboptimal amounts of fluid. So there is no evidence, or there wasn't any evidence, that routinely giving fluids at the end of life was either good or bad. And yet our practice is very dogmatic. We have people who are very pro and there are people who are very against. But what we need the research, and we'll take out the angst associated with this problem. Because then we will be able to have informed conversations with patients and carers. You can't have an informed conversation if you don't know what the pros and cons are of an intervention. So I appreciate I'm coming to the end of my time. This is a quote that I like. It's actually a quote that's been reproduced in the Oxford textbook of palliative medicine. And it's about, yes, research is challenging and it takes up resources and whatever, but there are good reasons for doing it. And if we do the research of the interventions that we currently use and we find that they are very effective and well tolerated and better than anything else, then that's great. That's what we should be doing. We should be just as Mike was talking about collecting data, prospectively about how we're doing. We should be have the same confidence that when we give an intervention, it's the best thing. It's backed up by the research. So I just leave you. I think this is my last slide. That palliative care is about holistic care. And empathy is really important, and caring for the whole patient and the families is very important. But empathy is not a substitute for evidence. And you can be nice and follow nice guidance or other guidance and follow the research. And actually, if you look at what patients want, what they rate most highly in terms of a good death, it's about having their symptoms well managed. So I think it's our duty to actually make sure that what we do is appropriate. And I will stop sharing my screen now. Thank you very much.